Welcome to today's webinar, which is part of the Translational Applications in Public Health mini-series, a collaboration between the Institute for Public Health and Medicine and Northwestern University's Clinical and Translational Sciences Institute, or NUCATS. I want to remind all of you that you're welcome to ask questions of our presenter at any point during the presentation today. To do this, please use the Q&A function, not the chat function, as we will be monitoring only the Q&A for questions. Our special guest today is Dr. Hendricks Brown. Dr. Brown is Professor of Psychiatry and Behavioral Sciences and Medical Social Sciences here at Northwestern University's Feinberg School of Medicine. Dr. Brown is an internationally recognized expert in implementation science methodologies. He is also director of the NIH NIDA funded Center for Preventive Implementation Methodology for Drug Abuse and HIV, also known as Ce-PIM, which is the only NIH funded center focused exclusively on implementation methodology. Today, Dr. Brown will present on the topic of reversing the flow, how implementation science can improve health equity. Please join me in welcoming Dr. Hendricks Brown. Hendricks?
Thank you very much, Ron. I was just remembering it's been about 8 years, almost to the day, when I joined Northwestern. Ron, you were one of the first people I met, and I'm just really pleased about the kind of work that you've been doing with IPHAM. It was a great opportunity to link up at Northwestern, and I really appreciate that. So thanks for the invitation and all of the last work together with 8 years. I do have some funding announcements. If I went through all of these in detail, we wouldn't have any time for the projects, but all of these involve implementation science, and they are moving towards the work around health equity as well. So there's the NIDA grants from the Ce-PIM that Ron mentioned in here. We have a supplement to look at COVID-19 impact on HIV and drug abuse services in Pinellas County. I'll mention some of that in here with NIH. NUCATS is an important part of this, IPHAM as well, NIAID with the Third Coast CFAR, NIAMS with the First Daily Life P30 that Lehman Sharma organizes and runs in here. Rick Lieber's work with the Ability Lab and CDC Center and new ARC funding, which has just been identified in here. I also wanted to acknowledge at the front a lot of the people that I work with on a day-to-day level, that includes all of the people on this program called Bridges that we have. These are listed in here. It links up community, service delivery, and research. And in the middle of that, intersecting all of those, is health equity. I'm going to just point out one community partner that we have that we've been working with, and that's the Pinellas County Opioid Task Force, which gives you some idea about the intensity and breadth of the work that's in here. Many of the other community partners are part of what we do as well. So here's the outline of what I'm going to talk about today. I'm going to start about terminology, talk a little bit about implementation science, some of the elements of that, and particularly around methodology, because we have a center on methodology in here. We'll talk about equity and a couple of issues related to that, including what we've been calling scientific equity. And then we'll get to the content in here of reversing the flow, paradigm shifts that need to be needed in here to advance equity and implementation science. And we'll talk about interventions, implementation strategies, and methodologic approaches in here. Then we'll go into a summary. Throughout this, we have a cross-cutting theme, that is health equity. And for health equity to succeed, we need to force a revolution in science. That's not stated lightly. I do think we need something of this kind of magnitude in order to change the culture and scientific priorities of NIH and as well as Northwestern. building in more completely a voice of the community in here, recognition of root causes, including systemic racism, different methods and interventions, as well as training and mentoring. So those may be topics toward the end that we can discuss in here. When I talk about implementation methodology, I'm talking about measures, models, and testing. Here's a couple quick measures associated with this. Implementation barriers and facilitators is something that is standard in the implementation world. Implementation strategies, what do you do to deliver evidence-based programs? How do you measure fidelity and sustainment? Those are the kinds of things that we need new measures to look at specifically. Models include the implementation logic model, health equity implementation frameworks, as well as agent-based models. It gives you a breadth of the kind of work that we've been doing in there. And then testing includes randomized implementation trials, formal randomizations, ones that are not randomized, pre-post designs, demonstration projects, policy implementations, and even de-implementations. So those are the kind of things that we do on a daily basis, and we integrate those with a large group of content areas, including mental health, substance abuse, violence, chronic disease, and other things. So here's the definition that NIH uses for implementation science, and I think it's worthwhile to start with this. It's a scientific study of methods to promote and systematic uptake of research findings and other evidence-based practices into routine practice. Here's the point about it. This is I think, a limited definition, and we will come back to this one. One piece in here is it's skewed towards the NIH traditional translational pipeline, which we'll see in a moment. Big thing about it is it has nothing, says nothing about equity. And I think that's a mistake from the very beginning, and it's something that has to be corrected. So when we're talking about implementation, we're talking about two pieces in here. One is evidence-based interventions. That's the what we want to deliver. Implementation strategies are how it gets delivered. Just a simple idea about how do we combine or distinguish these. We think of the evidence-based clinical and preventive interventions as 7 Ps. These are examples, pills, programs, practices, etc., that correspond to examples in the HIV prevention field. PrEP being one that we will talk about as an important measure associated biomedical intervention to reduce the risk of infection. But then we also talk about system level strategies for implementing these evidence-based interventions in here. We talk about logic models, and our colleague J.D. Smith and others have written a paper recently in implementation science on a logic model for implementation. Feedback mechanisms are important because we have a service system that is needing to deliver those programs in here. And Carlos Gallo is the first author on that. And then we can talk about what kind of categories these system level implementation strategies fall in. And Byron Powell has a paper on that. So there are references. Almost all the references that I'm putting down in here are on our website that you can go to. A few of them, like Byron Powell's, is separate though. So we're likely to know what to do. Those are the 7 Ps, but not necessarily how to do it. So implementation really talks about the delivery system. It is essential. Here's a good illustration of this one. The use of effective interventions without implementation strategies is like a serum without a syringe. Cure is available, but the delivery system is not. And if that doesn't really say something about what the status is around the COVID-19 vaccines, I don't know what is. So it's really in the focus around how do we do good, careful implementation. Here's the diagram that NIDA actually used years ago. We revised this a little bit about the traditional translational pipeline at NIH. It starts off with pre-intervention studies. Those could be basic science studies, but they could also be programs that are delivering looking at epidemiology, but then it goes into typical studies, often randomized trials. Efficacy studies is the first group in here, and they're answering the question of could a program work under ideal conditions. If you move up the ladder in here, programs can go get tested in terms of effectiveness studies. Those are questions of does a program work in more realistic settings, but also with the supports of the researchers to make that happen. The third phase in here is really around implementation research. And that is fundamentally asking the question of making a program work in real settings by itself. There are multiple ways of organizing implementation research and linking it to practice. This exploratory, preparatory implementation with fidelity and sustainment as one EPIS model that people use, and there's a breadth of work associated with local knowledge to generalized knowledge. But what all it really basically means is we're typically in this model, we're embedding an evidence-based program, something that's already gotten through effectiveness typically, into a complex system. So that brings us to the title of the talk in here, Reversing the Flow. And of course, if you look out your windows, you may see the Chicago River. It was considered an engineering miracle to move the flow of the river in here to lift Chicago out of the swamp. So we're doing something, asking for something similar in here when we're moving in and trying to deal with how do we improve health equity. And in fact, engineering is an important piece to this one. This is some work that compares the scientific method versus the engineering method according to a number of different steps in the process in here. Sanjay Mehrotra was the one who put this together in here, and Carlos Gallo is the first author in this paper. And I'm just going to highlight a couple things in here, just as a comparison. In the scientific method, we ask a research question. Engineering, it defines the problem to start off with. Background search and things like that are the same. Constructing a hypothesis is a core step in the scientific side, whereas in the other one, in the engineering, you specify requirements. And then you get this big box in here. On the left-hand side is testing with an experiment, letting it rip and go through 5 years of grant funding to see whether it works or not. Efficacy and effectiveness studies particularly, but also in the implementation world. On the right-hand side, you can see that there's a lot more arrows in here, and changes and adaptations are going to occur over that period of time. So I call this left-hand side, the scientific method, is let it ride. It's like going into a roulette wheel over and over again, putting out the same money each time in here and seeing whether you get the results that you want. On the right-hand side is adjustment. And I think we do need methods that do fulfill more of the engineering side than we've been doing so far. So here's what I'm going to call the paradigm shift number one. I'll get it in about 5 paradigm shifts over the talk today. And that is, there are existing scientific standard for interventions focused around NIH. That is, do a fixed intervention or an implementation and let it ride for those period of time to seek generalizable knowledge that could be used as broadly as possible. That's not going to be as effective all the time, particularly in implementation, as putting in a way of including engineering approaches. That gives you much more opportunities for learning and adapting an intervention. And just an example of that one, PrEP, for example, is a pill. But what happens in the middle of a trial that you're testing of a pill and there's a long-acting injectable that's shifted in here to be tested? That's the thing, or that's the one that you'd like to have evidence-based, and it could just reverse all of the work that you're doing in a very careful study. You can also think about implementation strategies. In the middle of this pandemic, telemedicine started to get reimbursed. That really made huge shifts in how you deliver the programs that we know, think, or believe they think it'll work. So that's what we've been calling translatable knowledge, not as contrast to generalizable. We know, for example, that health in the United States is many places not only very costly, but also poor compared to a lot of the other developed countries. And this is kind of a picture that the US is 50% to 100% higher in terms of the chronic disease burden than many other developed countries. And it has three pieces in it that we've inherited over a period of time. Our health programs that we want to use in here are too slow to move evidence into practice. They're too weak to impact in populations at levels that we want to have, and they're too exclusive to address health equities. So here's what we mean by too slow. This is a classic example of the translational practice in here, where people say it takes about 17 years for a healthcare program in here to be to deliver on the research benefits, and only then you get about 14% of those that happen. And this can give you some sort of illustration of this. Here's an example of this one. PrEP is now about 17 years since it was started in here with the research in 2004, and you can see the results of these efficacy and effectiveness trials, and then moving on to practice approvals and local implementations in here. Latest information about this one that came out this last year, there's still only about 8% of those men who have sex with men who are eligible to get PrEP who are taking it. And of those, 1/3 of them discontinued. So that's not a good model to try to approach in here. There's something fundamentally difficult about trying to bring together evidence-based programs. PrEP is very successful in reducing infections, but we're not getting it out to everybody that probably could benefit from it. Here's another example, ending the HIV epidemic. Fauci wrote this in 2019 with a presidential mandate to reduce incident cases by 75% within 5 years, and then 90% within 10 years. There are 4 pillars in here: diagnose, treat, prevent, and respond. Many of you are part of this big effort right now. But here's the question you'd have in here. How do you tell whether you're going to be doing the right thing over a 10-year period? You have a goal of 10 years. You're working hard to try to build in evidence-based programs and deliver them successfully in here. But we can't wait 10 years to conduct a randomized implementation trial to compare alternative implementation strategies to tell us whether or not we would do any good. So implementation involves a complex system. It's useful in here, and we've been working on this one, of using simulation modeling of complex systems, particularly agent-based modeling with our colleague Uri Walensky here at Northwestern to do this. Here's an example that comes from work that is still unpublished yet, but the basic ideas in here are in this reference from Landsberg. We looked at over 2,000 combinations of how you could be delivering PrEP and ART medications for preventing HIV transmission and for treating those who were already infected with HIV, and looking at over 2,000 combinations, and then pick the ones that meet, through simulation work, the 90% reduction that was intended in here. So in this diagram in here, we're looking at the top of over 2,000 combinations in here. The ones that are red are the ones that don't get close to the 90% reduction. And the redder they are, the poorer they are, where the blue corresponds to things that are better. And if you look down here, this chart indicates bifurcations of ART retention versus lower levels of ART on the right-hand side and higher levels on the other side. And if you go down to the left in here, you finally get to a place where about 2/3 of those combinations of interventions that are focused around ART and PrEP together look like they could benefit and make the 90% reduction. You can summarize those by looking at ART medications. You'd have to have a highest level of retainment that we looked at, and PrEP medications has to have linkage and retention as high as possible, and adherence is next to highest in here. And that's about the only way that you can do it. So there's really an intensive amount of effort, and PrEP is a fundamental piece of this one in order to make that. So here's our translational pipeline again. That's our standard model in here. But when we take a look at this, in terms of what NIH is actually funding, it looks a lot more like this. So could a program work? There's a lot of work with that, and does a program work and effectiveness, but in the making a program work, the implementation, it's much smaller. J.D. Smith and a set of colleagues in here went back to the last 5 years of NIH-funded grants and looked at those. Only 4% of those NIH-funded grants dealing with HIV were implementation science related. And we think that's a mistake. We think that this is, we know enough now that we should really put a lot more effort into it. At the same time, we can't forget the disparities in here with African Americans and Latinos having much higher rates of HIV as well. So getting back to this issue of what is wrong with the current system in here, the system we have is too weak. We can get the best possible evidence-based program we have, but when we start thinking about a delivery system in here, it's multifaceted, and you can think about 50% getting adopted, 50% of those providers being trained, 50% of those trained providers choosing to deliver it, and then 50% of the eligible patients receiving it and adhering it. When you get all together in here, you multiply that out, and you get 6% benefit at a population level. So we've got a fundamental problem in here if the delivery system is not tuned and designed to deliver very effectively. So here's another paradigm shift. NIH now prioritizes innovative intervention knowledge, and there's nothing wrong with that. But what it really does say is if you really want to make impact on populations, you need to really put much more resources in the implementation and delivery of things. And our health system is at poor at follow through, and particularly in this issue of looking at disparities. So here's what we mean with equity. This is sort of indicative of the challenge we have and the American view of equality, which on the right side is essentially limited to equality of availability, but it doesn't mean the same as actually getting the benefits that you might have. And we think of this as equality of functioning on the right-hand side. So I'm going to switch to another topic in here that we've been working on, and that is looking at drug overdose deaths. This is US data through July 2020. The number of overdose deaths in here continues to run and increase over time. And you can see that there's not too much difference overall at a national level between white non-Hispanics and black African-American non-Hispanics in terms of their overdose death rate. But when you go to different populations, here's what Illinois overdose death rates look like by race and ethnicity 2 years ago. The first dark bars correspond to white non-Hispanics, and the blue bars correspond to Black or African-American non-Hispanics. And you can see that there's more than a twofold increase in here for African-American mortality by overdose for any drug, opioids, synthetics, heroin, etc. There's a lot of changes that were going on this last year during the pandemic. This is a 2-year sequence of what was happening in Illinois with the overdose deaths in here. And I'm just going to point out about May was the top time in here in 2020. And there was a big bump in there, but it looks like it's going down much more towards where it was the previous year. So that was more of a temporary kind of effect. Here's what it looks like in Pinellas County, where we've been looking at it. This plot is the Number of monthly deaths in here, starting in 2018, which was about 20, and now it's well over 40. It's doubled over that period of time in 3 years. And it continues unabated over this period of time during the pandemic. So one of our jobs is to look at what's happening. I will make a point in here that Black and African Americans have much lower death rates in Florida than they have with white non-Latinos, but they're much less likely to receive evidence-based treatments that do exist for opioids. And I'm going to run through these relatively quickly in here. This is cumulative numbers of seized opioids over a period of time from 2018 into 2021. These are from the police. It gives us an indication of what drugs are available in here. It's not perfect by any means, and it's in Pinellas County. And a straight line in here says that the number of opioids in here is about constant over time because this is cumulative. So the straight line in here indicates that it's about the same over a period of time, and you can see that there's not much difference in here with the dashed line, which is the extrapolated version, and the solid line, which is what you actually see. But here's what it looks like with seized heroin. Big difference in here during the time when the pandemic started, where if it was projected to go on in here, we would find more police picking up heroin from the streets. But here, it's much less than that. Instead of heroin, though, what's happening is fentanyl is increased in here. And fentanyl is a much stronger drug. It's an opioid much stronger than heroin in here. Same thing with stimulants. Not much change overall with stimulants. But cocaine is going down, whereas methamphetamine is going up. So these are complex pieces to what's going on with the opioid mortality, causes of opioid mortality. So we have a lot of different pieces of information that we need to pull together in here. The NIH scientific standard for generalizability is essentially let it ride. We can get information in here from randomized trials of which to base decisions and use them across a wide diversity of issues. That's not necessarily going to give you enough information to use across time in different settings in here. It doesn't provide as many opportunities for learning as we need, and we need an underlying applicable model that is informed by local data. So that's what we've been working on. Dr. Vermeer in our group has been doing this one. I'm going to put in here, this is Pinellas County in Florida, input, process, and output. This is the agent-based model components or modules in here. As demographics, overdose module, Narcan model for rescue for people who are overdosing. And what's changed in here, what's unique, is input data from that county, for example, as well as county resources, costs, and priorities. And the output there can be what is the ranking of alternative choices for making decisions around how best to deliver rescue with Narcan as a medication. So I'll switch now to looking at what we call scientific equity and its role in implementation research. So we've defined or given you an illustration of what equity is, health equity, health service equity. We've been talking about scientific equity, and I think this is something that is important in terms of the direction that we go and reversing the flow. Equity and functional needs a functionally sufficient amount of scientific information that's produced to understand not only the causes, but the solutions to health disparities. When I talk about health solutions, I'm talking about implementation. A couple references in here for this one. We're nowhere near this. Even the number of people who are Latinos in clinical trials is about half the US population. We don't have as many minority PIs in NIH RO1s to be reflective of the overall population. And few of the effectiveness or implementation studies are focused on minority populations itself. So here's some work that Nanette Benbow is led in our group in here that came out last year around the epidemiology. It's just county level Latino disparities and HIV prevalence. So on the x-axis is the non-Latino white prevalence. On the y-axis is the Latino prevalence. And this arrow corresponds to pointing to the y equals x line. That's when there is no disparity. They're the same rates. What you see is almost all of these dots, and each of these dots correspond to one of the 775 counties in the United States. 95% of those have higher prevalence than non-Latino whites. It's striking. Not only that, but this dark blue area corresponds to an area where the Latino disparity in here is 10 times that of white non-Latinos. There are areas where it's about equivalent. If you look at here where the non-Latino white prevalence is high, generally the amount of disparity is pretty low, or very close to that line. But when you look at the other side of the curve, in situations where the non-Latino white prevalence is low, you see high Latino prevalence. So that gives you an idea of where to look and understand some of the causes associated with that. So now I'm going to switch to implementation for HIV prevention or treatment. And this is work that J.D. Smith and Nanette and others have done in here, came out. And it really talks about what the level of scientific inequity is for Latinos around HIV. So if you look at Latino population proportion, it's about 18%, but the proportion of the studies in here, these are all of the NIH studies over the last 5 years that were implementation related. There's only about 3 or 4% or so that were in this group. So we do have a big issue in here in terms of some populations are not getting the attention at NIH research, particularly at the level of implementation end of the pipeline. I think this is so big that if we were studying child welfare, this would be a case of organizational neglect, and we would be doing something about it. Here the organization is NIH, but I don't want to put all of the concerns about this at the NIH level. Is the scientific community being complicit in not addressing issues of disparities associated with this? So here's a paradigm shift number 4. NIH often has this kind of perspective of we can just carry over with minor changes available of implementation knowledge when we want to apply it to minority populations that have historical disparities. But that's not likely to actually work. What we need to do is conduct implementation research that covers the needs of populations that do experience this historical disparities. And it's even a bit worse than this one. The current dominant flow of research practice and policies to address disparities certainly is emphasizing the identity of the disparities, not the solutions of those. And when we do look at this one, many of the interventions that we've done so far are ones to help marginalized populations better navigate our current service systems without really dealing with systemic change. We need to really think about rethinking how do we engineer programs that rectify those factors that actually generate the disparities in social determinants themselves. I want to give an example of what some of the best work that's being done, but it's still in this kind of frame of let's address the issues of systemic racism in organizations. This is work from my colleague, Velma Murray, who developed a strong African American families, and she has a component in here that she calls encouraging racial pride in here, looking at ways of handling discrimination, building positive racial pride, being assertive in situations where the kids are feeling that they experience racism, for example. So we still have a lot more to do if we're ever going to make any kind of shifts in here besides this. So let me mention about one other point about reversing the flow. It may be better to try to have less concentration on evidence-based interventions and more try to fit the needs of the community. So here's a quick statement that I pulled from one of the people making a grant proposal. I would like you to read this. I'll read it along with you in here. Smartphone apps and telehealth increase access, but often fail to reach underserved populations. What I think we are doing in here is reversing the way we are doing it. We take interventions that we know something about and then try to apply them to an underserved population. I think that's limiting in here. And in the absence of scientific equity, the only interventions that we can get are lifted or adapted from those tested in the dominant culture. And we need more than that. And we are not producing enough to do that. I'm going to finish it up here with one comment around scaling out, which is an efficient way to conduct implementation research. We don't think you can do everything at once in here, but my colleague Greg Ahrens was first author in this one. And it is distinguished between scaling up, which is really taking an intervention that's evidence-based and applying to the same population, the same delivery system, with either a different population or a different delivery system or both. So here's the traditional translational pipeline. And if you think about what we normally do, is we take one context and run it through the entire cycle of this pipeline. And then we go through another one, and then another one. Well, that's 30 years down the lane, trying to get this one. So what can we do as an alternative strategy to this? And that is scaling out. The concept is borrow as much strength. So do the work going through the pipeline in here for one context, and then borrow as much strength as you can for these different contexts. This is a quick final message in here for looking at a conceptual theory about this one. It requires that we have a mediational model for scaling out. Here's an example. We know that PrEP can affect HIV in here, but it has to go through adherence. If the adherence is low, we get very little effect in here. The relative risk is nearly 1. But if we have high adherence, we have a very strong effect in here. So the idea is to really emphasize and measure adherence as being the core piece in this one. We've put together a sequential mediational model for implementation that starts with implementation fidelity as well as intervention fidelity, and it goes all the way down to distal outcomes in here. I'll let you go to the other paper if you'd like to get more detail. So let me summarize. Implementation research needs to play a larger role in translation. And I think it's stronger. If implementation would be a failure if it doesn't succeed in producing health equity. Here's a couple of examples of a scientific revolution. I don't mean to take away all of the things that are going on with the good parts in here, but the implementation science definition really needs to add in health equity at the definition in here. I urge people to do that. It needs to be more adaptive, so this let it ride kind of approach that NIH is kind of using for precision in here really needs to be translational, incorporating some engineering. And then finally, we can't wait for implementation to go through the traditional translational pipeline. You can use agent-based models to do what-if studies around decision-making. We can use scaling out in here, and we can prioritize implementation and studies with historical disparities. So here's the last piece in here. We do need to look at rewriting the rules of dominant research culture. This goes back to Pogo in 1971. We've met the enemy and he is us. I do think it does need to look at some introspection. Here's a couple of examples. It's not mine per se saying this one, but I think a lot of the researchers working in this area talked about looking at racism and not race, equity and not disparities, culture of scientific equity, and they developed this new generation, not only of methods, but also researchers to support equity and rigor. So I mentioned, I'm going to end in here with pointing out that the NUCATS program does have a pilot research award of $30,000. It's due July 9th, and I'd like to have people apply for that. And there's also a dissemination and implementation reading course that we've had 3 of them so far in here, and we plan to have others. Finally, I invite you to join in the Prevention Science and Methodology group that has weekly virtual grand rounds, including ones on systemic racism and other areas in here. And finally, if you want to have references to some of the work in here, you can go to the Ce-PIM website. So thank you very much. Pleased to have comments and questions.
Thank you, Hendricks. That was wonderful, as usual. And we do have a few questions from the audience. Let me help moderate that. The first, I think, is, let me paraphrase the question just a little bit because it was related to an earlier slide. But I think that the context for the question is when you have an evidence-based practice that you're trying to implement in a delivery setting, and there are challenges. How do you balance fidelity to the evidence with trying to adapt that intervention into different forms so that different types of deliveries with different capacities can feasibly adopt the evidence?
That's a great question in here. We historically thought all you needed to do was define exactly what the intervention was, do the intervention over and over again. And I think we've really moved away from that one. The contexts are so important in here in terms of the overall population that you're serving. Think about an app, for example, that is designed for adults and then try to apply it to kids. It's just not going to work. So I think really paying attention to this one, using user-centered design concepts and others, where community engaged research is a major part of building an intervention that people would want. People also talk about, it's much easier to have an intervention where it's like a string that you're pulling rather than trying to push a string because not very many people want that. So I think the concept, is there. The real trick is really doing that with precision, of trying to balance those two factors.
And could you, another question relates to maybe the similarities and contrasts between implementation science and learning health system frameworks. How do they work together? How can the two be used in harmony to address health inequities?
When implementation science is probably as a field really defined about 12 years ago or so. And at that point in time, I think it was quite limited. And it took passing knowledge to, issues where people had learning health systems of looking at collaborative models for learning collaboratives, for example, and programs that were derived to improve the quality of programs as they were administered in here. I think it's a richer field than it was years ago, and it does now incorporate a lot of the things that are there. And in fact, one of the things that is weak, I think, in what many people do in implementation science that I think it would be useful is to do much more monitoring on a routine basis of what are some of the major elements of the intervention and whether or not they're working the way that you intend. I do think that there are a number of learning collaborative models, which is one part of sort of the learning health systems. It's not the major part of it. We've run a major randomized trial of looking at 2 implementation strategies, one working with counties delivering an evidence-based intervention for foster care that was individually based at the county level, and another one was based on a learning collaborative of about 6 or 8 counties working together. What we found is that learning collaborative did succeed in producing more impact in those counties that were able to get that. And we did that with a randomized trial of 51 counties in two states. So I think that there's a lot of collaborative work that can be done in here and more to do.
Hendricks, another question relates, I think, to the EVIs tend to have a strong, underpinning in efficacy or effectiveness research, and so it's known to be evidence-based, and we then develop implementation strategies to try to put those into practice. When do the implementation strategies become evidence-based? How do we know that there's sufficient evidence that they should be scaled? How do we measure that? How do we monitor it? And how do we sort of make that transition?
Yeah, so the words get a little bit jumbled in here, but there are, in fact, effectiveness can be applied to implementation strategies. A good example of that is the Communities That Care, or CTC, that came out of the University of Washington group of looking at programs that were going to be delivered to address issues of violence, drug abuse, and other topic areas for kids. And they developed this Communities That Care model, which was really a platform for delivering, for having communities decide which interventions they would be able to use that were evidence-based. It has been tested in randomized trials, randomized implementation trials, where communities were provided the resources to deliver that Communities That Care, which is about an 18-month process or so, versus ones that did not get it, and then measured to see whether or not there was uptake of evidence-based programs on either one, as well as impact on kids. And both were benefiting from those communities that got the Communities That Care. There are not very many of those that people have done, but I think that that's what the next phase of work needs to go to.
Hendricks, when we have a focus on health inequity, you talked a bit early in the talk about overall strategies for using agent-based and other forms of modeling to sort of predict, I guess, reach effectiveness, or you have a 50% drop in the number of systems, or the proportion of systems that can adopt an EBI, and then can the professionals be trained to deliver it? Can do the individuals receive and take the treatment? I think you talked a bit about the lack of detailed information about differences by race, but are there ways that we can use existing data, even retrospectively, to look at and model differences at each of those steps by different race, ethnicity groups, or, if we've identified a health inequity, to predict where the greatest drop is that causes the inequity?
We haven't been collecting that data as systematically as we need. I think that's a really fundamental step that we need to do. There are some specific pieces that I think you could do. So one example is with the cascade of care for opioids, for example. There is one that matches what HIV cascade of care looks like. The data from Florida that we were, my colleague Kim Johnson led this paper, looked at where is it that where the disparities start to arise. And the biggest message was that it comes in with whites who have opioid use disorder come in and they get a primary diagnosis of opioid use disorder. Blacks come in and they get a secondary diagnosis to something else. And because of that, they don't get treated as often with any interventions that look very effective. And they probably come in from different systems, more often from the criminal justice system, as opposed to going in through the standard medical system in here. But we don't do that routinely. And I think this is a big gap that we have in our system of finding out exactly where it is those differences are. That's the next generation of work, and we're certainly deeply interested in that and the kind of work we're doing.
We received a comment that I think was a point you made earlier, which was that you know, in a lot of cases, the evidence base that we have today has been demonstrated largely in dominant race groups, just because clinical trials are underrepresentative of a lot of race and ethnic minority groups. So, you know, there's certainly, you made this point, but I don't know if you want to say anything else about the need for really just efficacy research and clinical trials that are inclusive of those populations.
Right. So we went back, and one of the areas that I think is important in our armament of new science in here is to synthesize findings from multiple studies, particularly with minorities or portions of the population that are relatively small. We don't usually get enough power to even describe what happens at a single study, but only by combining those studies can you get very far in there. So we did a NIMH study looking at a synthesis of 19 randomized trials in terms of preventing depression in adolescents. And what we found was, yeah, there was benefit overall, but there was a real distinction in here between interventions that were specifically targeting depression and those which were more generally useful for general mental health. In the population that was the ones with the specifically dealing with depression, it only included people in it who were white, who had their parents had college education, and that they had high salaries. So we have a disproportionate number of individuals in there, and even those studies that had 5,000 kids in it, we only found 1% who are African American. And so we're really not looking across the spectrum of individuals who could benefit from these interventions successfully.
How much of that do you think, Hendricks, is also our responsibility, you know, as institutions to, you know, write strong research that focuses on studies that will represent those populations that you're giving some specific examples, but, you know, NIH needs to fund it. We also have to have investigators doing work in that area. We have to we have to be mindful and purposeful in our attempts to have representative recruitment. And I'm not sure how well you think we hold ourselves accountable to that, even at Northwestern, and how we might improve.
I think this is the crux of the issue. We had an experience in here. I was one of the faculty at the Implementation Research Institute at the Washington University. That's been an NIH program, a stellar program in delivering training for this next generation of leading implementation scientists. It's a widely diverse set of implementation scientists in there, but when you look at what they are doing, most of them are working with populations that are not very diverse. And it was distressing. And it's because the opportunities, particularly in many universities like Northwestern, that don't have as much reach into a general population, it's easier to sort of join in and work with populations that are not as diverse. I think there has to be a commitment that you can start there, but you can't end there. so that if you go through and do work like we're doing and looking at implementation of a collaborative care model for depression in the clinics in the Northwestern system, that we need to try and move from there to looking at what would happen if you used the systems like that in FQHCs around the city of Chicago. Also, I think we need to do more partnering in here with populations that are delivering programs across the country that are working in with Latino populations, African Americans, Native Americans as well.
Well, we only have 2 minutes left. There's one additional question. I'll just give it to you, and maybe you can take it quickly, and then close with anything else you'd like to add briefly. The question relates to whether there's a role for the legal system, and I would interpret that maybe as laws, rules, mandates in moving interventions to the communities that need them. So in that sort of scaling out stage, you know, is there a role of the legal system and a policy?
Yeah, back when I was going to graduate school, it was at a time when the civil rights movement really benefited from the legal system. We haven't really been able to mount that, particularly over the last 4 years, but I think it's a missing piece in here. If you look at what the Affordable Care Act requires, we're not giving enough priority to mental health and substance use as we need to, for example. So I think it's really an important partnering that we need to do.
Well, thank you so much, Hendricks. We really appreciate you taking the time and giving us such a wonderful presentation today, and thankful to NUCATS for co-sponsoring this webinar, and also their sponsorship of the D&I pilots that you talked about, which sound like a just tremendous opportunity for funding.
Great, thank you very much too.